Thank you, Dr. Ruin. Thank you to Dr. Coleman and Dr. Leonard for the invitation, and congratulations to Dr. Ruin for a great session and great talks. Today I'm going to speak about who should get CAR-modified T-cell therapy for relapsed and refractory diffuse large B-cell lymphoma. This is my disclosure slide, including honoraria from companies that have had CAR T-cell products approved, as well as research funds. The outline of the talk is really what are the indications and who should get a CAR-modified T-cell in 2019, including the FDA products, as well as reviewing some data from real-world experience at a multi-center level. Another question that comes up in clinical practice is, are CAR T-cells safe or efficacious for central nervous system secondary lymphoma? What about the role of CAR T-cell in potentially consolidating a remission? And then, are CAR T-cells really the patient's final therapy? Is this a therapy that we infuse a CAR T-cell, put our hands in our pockets, and hope? And then some summary and considerations at the end. So I'm just going to briefly review the clinical data from two prospective studies that have garnered FDA approval for CAR-modified T-cells. This is axicabtagene ciloleucel studied in the ZUMA-1 study. Axicel is a CAR-modified T-cell that targets CD19 with an scFv that's engineered to a CD28 co-stimulatory molecule conjugated to the business end of a T-cell receptor. The investigators, including Dr. Nilapu, outlined that the SCHOLAR-1 data set, which was a retrospective data set from a multi-center effort, revealed an overall response rate of a patient population that has received at least 2 lines of therapy of 26% and a median overall survival of 6.6 months. So the phase 1b into phase 2 single treatment study was eventually divided into 2 cohorts, including relapsed refractory DLBCL and relapsed refractory primary mediastinal large cell and transformed follicular lymphoma. You can see the primary endpoint in the phase 2 was overall response rate with key secondary endpoints, including overall survival. This is the consort diagram of the ZUMA-1 study. As you can see, 111 patients were enrolled and 101 patients were treated. All patients received standard cyclophosphamide fludarabine lymphodepleting chemotherapy prior to infusion as per prescribed on the protocol. Axicel was infused at 2 times 10 to the 6 CAR T cells per kilogram. This was a multi-center effort with 22 sites, and Kite Gilead would like to highlight that there was a 17-day average turnaround time in manufacturing. So here are the primary endpoint data. Looking at DLBCL as well as the secondary cohort of transformed follicular lymphoma and PMBL, I would like to draw your attention to the combined data looking at or reporting a CR rate of 54% and an overall response rate that exceeded 80%. Here are the Kaplan-Meier curves as of Lugano 2017. This has been updated in the New England Journal of Medicine as well as Lancet Oncology most recently this year with a follow-up exceeding 24 months. But at the time of this presentation, you can see that patients that achieve a complete remission, there is some durability that has been demonstrated in subsequent publications with a tail on the curve in a small subset of patients, approximately a third or less. But I do want to point out that the patients that achieve a maximal response of a partial remission, you could see the fall off immediately following month number 1, which was the first end of treatment restaging as prescribed by the protocol. These are the data that garnered the FDA approval, looking at overall survival benefit compared to the retrospective SCHOLAR-1 data set. You could see a significant overall survival improvement in comparing the prospective ZUMA-1 study to the retrospective SCHOLAR-1 data set. When looking at covariates in terms of 6-month PFS rates, as you can see, none of them came out to be significant. There may be a small signal in patients with bulky disease as defined by greater than or equal to 10 centimeter tumor mass, but that was a very underrepresented patient population. But as you can see, none of these came out in univariate analysis. A secondary analysis that was presented at ASCO in 2018 by Dr. Locke, the ZUMA-1 investigators split the patient groups into tumor mass or tumor volume as measured by sum of perpendicular diameters into 4 quartiles, and you can see there's a steady decrement in durable remissions with regard to increasing tumor volume in the 3rd and 4th quartiles. There were two important presentations at the ASH meeting in 2018, nearly a year ago, looking at the quote-unquote real-world experience, largely at large academic medical centers, with axicabtagene ciloleucel that was the first to be FDA approved. This is a presentation by Dr. Nastapil at MD Anderson and the ZUMA-1, many of the ZUMA-1 investigators and participating sites. This was abstract number 91. The Cohort Diagram on their retrospective analysis, as you can see, 295 patients were leukapheresed, of which a large fraction of them actually underwent treatment, 274 with axicabtagene ciloleucel. So in the spirit of the modified intention to treat population, as was analyzed on ZUMA-1 and the other phase 2 studies, they note a denominator of 274 patients analyzed by modified intention to treat. Of note, in this standard of care axicell cohort, 40+% of the patients would not have been eligible for ZUMA-1 based largely on performance status as well as organ function. But as you can see in comparison between the two patient, comparing the two groups of the ZUMA-1 study, a prospective study with the standard of care on-label commercial patients, there was really no difference in toxicities. Of note, the standard of care patients received a significantly greater fraction of steroids once the signal of lack of signal of decrement to the efficacy of the product with steroids on ZUMA-1. There were a lot more steroids administered, and I'm not presenting that data today, but as you can see, there was no real difference in safety with the real-world group compared to the prospective ZUMA-1 study. These investigators looked at covariates that were associated with ongoing CR at 3 months. Of note, the median follow-up for this retrospective study was about 4 months in patients or survivors. As you can see, performance status, bulk, and whether or not you would have been eligible for ZUMA-1, which was largely enriched for patients with poor performance status, came out in the univariate analysis. These data have not been published in manuscript form as of yet. Here's the PFS and OS for the real-world group that was presented within this abstract, again with very short follow-up, but you can see the nature of the Kaplan-Meier curves. A second real-world presentation at ASH last year was a smaller group of patients, just over 100, with, again, a multi-center effort, largely with centers in Boston as well as others, including Ohio State and the University of Chicago, looking again at axicabtagene ciloleucel in the real-world population. This was 104 patients treated at a multi-center level, and this group wanted to define which groups were predicted to do poorly or have a poorer prognosis with axicabtagene ciloleucel. What they did note was day 0 CRPs, of which many of our centers are drawing inflammatory markers in series, given the correlation largely with toxicity, as well as the absolute lymphocyte counterphoresis was predictive of poorer durable response in univariate analysis. They also looked at the CRP at time of reinfusion as well as the peak ferritin, and as you can see in the two curves in the center of the slide, there was a significant difference in PFS in terms of patients who are quote-unquote more inflamed with either a CRP of greater than 30 or a peak ferritin of greater than 5,000. I would argue or suspect that this is related to disease characteristics. There was an analysis 2 years ago on the Transcend study, which is the JCAR17 study sponsored by Juno Celgene with the drug now lisocabtagene maraleucel, looking at predictors of the durability of response in early follow-up. All of these variables were found to be significant in terms of response rates, with the exception, interestingly, of the sum of the perpendicular diameters and tumor volume. But as you can see, many of these pro-inflammatory markers that are measured in series were predictive prior to lymphodepleting chemotherapy for actual response, as well as LDH. The second product that's been approved following axicabtagene ciloleucel is tisagenlecleucel, which is the product originally developed at the University of Pennsylvania. This, in contrast to axicabtagene, this CAR-modified T-cell product has a 4-1BB co-stimulatory domain. in conjunction with the T cell, the zeta chain of the T cell receptor and the scFv that recognizes CD19 as a tumor-associated antigen. This is the Juliet study Cohort Diagram. The patient characteristics on the right, again, in comparison to the axicabtagene ciloleucel study, both studies required patients to have an ECOG performance status of 0 to 1. Most of the patients were advanced stage, and nearly half the patients had undergone a previous autologous transplant. I do want to highlight in the Cohort diagram that 165 patients were enrolled to study, and 111 actually received Lysogene-like-Lucel through their vein. Again, this was analyzed by modified intention to treat, where 111 patients existed within the denominator in generating overall response rates in PFS and OS. And so one could argue that this was not a true intention to treat analysis. Here are the Kaplan-Meier curves for all patients treated on study. Again, 111 patients. And you could see the Kaplan-Meier curve for overall survival for patients that actually achieved a CR with occasional late events after 12 months. This is the most updated data that's been presented to date. The Juliet investigators did look at covariates in terms of prediction of overall response rate. I do want to highlight that there seemed to be somewhat of a signal, although not significant, in subset analysis for patients that had both refractory disease to the last line of therapy as well as tumor volume. So the current state of the science is that these two products, in addition to Lysocell or lysocabtagene maraleucel, are being investigated, as Dr. Sen pointed out, in one further line of therapy, proximal in the first relapse refractory setting in randomized phase 3 studies compared to standard of care platinum-based salvage followed by autologous transplant in patients that achieve a chemotherapy-sensitive remission. This is a relevant question in comparing the Kaplan-Meier curves of both of axicell as well as Lysogene-like-Lucel compared to the prospective Coral investigation, which was random assignment, Rice versus RDHAP in first relapse refractory diffuse large B-cell lymphoma with patients proceeding to transplant that achieved a chemotherapy-sensitive remission. So this is a completely irrelevant question. The ZUMA-7 study was the first to complete accrual, and the other two studies are ongoing. So a frequent practical clinical question is a patient that has progression of disease with secondary central nervous system lymphoma. Are CAR-modified T cells safe and effective? This is a presentation by Dr. Abramson at the ASCO meeting this year. This is data of 9 patients on the Transcend study, which is the JCAR17 Juno cell gene product in tabular form. As you can see, most of the CNS involvement, which is the sixth column to the right, patients had leptomeningeal disease as opposed to poor prognosis, deep parenchymal disease. But most importantly, and has always been a question to us as CAR T-cell practitioners, is with the advent of unique neurologic toxicity, was there going to be more toxicity with disease that's localized to the central nervous system? In this small group of 9 patients, that did not appear to be so. As you can see in the second column, looking under treatment emergent adverse events, there was 1 patient of 9 that had neurologic toxicity. Again, this is with a 4-1BB product, which appears to have less neurologic toxicity compared to a CD28 co-stimulatory domain that exists with the axicabtagene ciloleucel product. There's been a second publication that's been peer-reviewed and published in Blood this year, looking at 8 patients who had secondary central nervous system lymphoma and received Lysogene-like-Lucel, again a 4-1BB product, at a single center, a multi-center effort from the investigators in Boston. This is published by Matthew Fergault, looking at 8 cases. 4 of the 8 patients had a response, and importantly, no patient experienced greater than 1 event of neurotoxicity. So in aggregation, obviously this is 17 patients and not much experience, but the early signal, importantly with the 4-1BB product, is there may not be, or there potentially may not be enhancement of neurologic toxicity for disease that's centered within the central nervous system. What about the question, especially in light of more effective second salvage therapies or investigational agents or recently approved agents, for patients being bridged to CAR-modified T cells, what if you have a patient that actually achieved a complete remission while the CAR T cell is being manufactured, which has come up in clinical practice? This is a 8-patient series from the Juliet investigators where bridging therapy was allowed, in contrast to the ZUMA-1 study where no bridging therapy was allowed, wherein 9 patients actually achieved a complete remission to bridging therapy, and they had tisagenlecleucel then infused on study. At the time of this presentation, which was last year at ASH, all patients had maintained a complete remission, with 2 patients having been censored. This has now been published in Blood Advances, and I believe there have been 2 progressors. But these are the first real data suggesting that patients receiving tisagenlecleucel could potentially be consolidated in complete remission, and this has informed our decision at times in the clinic. Importantly, this has not been shown with axicabtagene ciloleucel, or has at least not been presented or published. So are CAR-19 or CAR T cells the last line of therapy for patients with relapsed refractory diffuse large B-cell lymphoma? The group in Seattle looked at patients who have failed CAR T cells and the clinical course thereafter, and you could see that patients both with early and late progression being defined by 30 days following CAR-modified T cell infusion, the median overall survival is not surprisingly quite short. Important considerations and important clinical findings that we're seeing in the clinic in patients that both achieve a remission or fail CAR T cells is significant cytopenias that has been well described in a recent publication in BMT, post-CAR-modified T cells, including significant neutropenia as well as thrombocytopenia. So this can be a real conundrum in a patient that maintains adequate performance status, potentially has low volume disease, progresses through CAR T cells, and then you're dealing with cytopenias in trying to get patients onto the next clinical trial or to the next therapy. So as a transplanter, I feel like I have to represent allogeneic transplant. This is contemporary data, combined effort from the European Bone Marrow Transplant Registry as well as the CIBMTR, the Center for International Blood and Marrow Transplant Research Registry, looking at allogeneic transplant by 3 donor sources: matched SIB donors, matched unrelated donors, and haploidentical donor sources, which are becoming much more accepted and in vogue with longer clinical follow-up in the post-transplant cyclophosphamide era. And what you can see here is the progression-free and overall survival is approaching 50% in these patients. Again, these are largely this is all retrospective data and largely likely selected patients. And then the third curve is GVH-free relapse or progression-free survival, so patients who are actually progression-free and without significant graft versus host disease. In this data set, nearly half the patients had a complete remission going into an allogeneic transplant, and approximately a third had a PR. So I think that becomes a question when we look back at the patients who achieve a partial remission to CAR-modified T cells, and the clinical question becomes, what do you do with those patients in a PR at day plus 30? So who should actually get CAR T cells? I believe that this is still the best therapy available in patients with second relapsed or refractory disease, especially considering that there may be a small fraction that have curability to the therapy. So I would say per FDA label. Emerging prognostic variables that are coming out, not surprisingly, tumor bulk, and then performance status and pro-inflammatory markers pre-treatment, which I believe are likely surrogates to tumor biology and tumor volume. The unique clinical situations that do have some data, although largely very limited, include CNS disease as well as consolidating a complete remission, both with products that have a 4-1BB co-stimulatory molecule and the consolidation in CR only with tisagenlecleucel that's been presented. And then I didn't present these data, but there is experience with post-allo transplant CAR-modified T cells, both on a prospective study from the NIH with Dr. Brudno and Kokendorfer, where donors were actually leukapheresis and CAR T cell products were generated. And we actually had a recent report in leukemia looking at 4 patients post-allogeneic transplant that got CAR-modified T cells. It doesn't appear to have complications such as risk of graft versus host disease in these patients. So post-CAR19 considerations, I think, when we're looking at a patient in clinic and deciding what to do, we know that 80% of the patients respond to this therapy, at least on the prospective studies. Sadly, less than a third of those are durable. So it's always kind of eye-opening to patients and families, given the excitement around this modality of therapy, that the likelihood is that they're going to fail this therapy. But I do believe it's the best we have. From both the prospective studies and the FDA-approved products, approximately 40% of the PRs at the 1-month PET scan, which was dictated on study, convert to a CR. But that leaves a large fraction of patients that are going to achieve a PR at 1 month and eventually progress. I personally think that this is a ripe patient group or group that is ripe for investigation, such as adjunctive therapy with checkpoint inhibitors, other immune active agents, or potentially allogeneic stem cell transplant. We have to be mindful of post-CAR cytopenias. And then, once again, a plug in is that in registry series, as well as many single-center studies, approximately 50% of patients are cured with allogeneic stem cell transplant, with the vast majority of those patients in at least some semblance of a remission at the time of allogeneic transplant. Thank you.